of nutritional practice, where today we'll be reviewing the function of the liver. The liver being the largest internal organ, it's also one of the largest topics that we're going to have to discuss with regards to the symptom survey. And as such, I'm pretty confident I'm going to run over the hour. So some of you have probably only budgeted an hour to spend on the webinar today, and that's okay. I am recording this webinar. It will be posted, a link to it on my webpage as soon as I'm capable this afternoon or tomorrow. So if you're unable to attend until the completion, that's perfectly all right. If you have any questions, you can send those to myself or to Joseph as necessary, and if you need to log out early, that's okay. But because I've got a lot of material and I'm excited about this topic, I'm pretty confident we're going to go over an hour. And I'd also like to be available to answer any questions. So for those of you that are just joining us, we're just about to get started. And if you have any questions or comments or concerns, you can throw it on the chat window down on the bottom left-hand side of your screen. And if I get an opportunity, I'll try and address those as they pop up. So let's start off with this quote that besides real diseases, we are subject to many that are only imaginary, for which the physician has invented imaginary cures. These have then several names, and so have the drugs that are proper for them. So this is from Gulliver's Travel, kind of a fantasy book. And I like the quote because it entertains me, and it sort of has something to do with liver, because liver is a process that gives so many rare and are unusual or very difficult to discern symptoms, and as a result, we're really looking at liver very indirectly from a lot of different angles. And so I think there's a lot of diseases that have very proper names like cancer and things like that that really have their genesis or their origin in problems of the liver. So, a further look into the symptom survey reveals that we have an intricate relationship between the symptoms in a group to other groups, and to the symptoms to all other symptoms as a whole. So what I expect for those of you who joined us for the digestive section last month and the upper digestive section the month before, we start to see that relationship between digestion and the liver and gallbladder and how one group affects the others. And keep in mind that it's the habits of the patient that cause the cascades of ill health, as it is also the habits that support good health. So more than talking about supplements and symptoms today, I also want to encourage you to look at your patients to influence their behavior and the things that they're doing, particularly putting in their mouth, as being very important. So anytime we optimize liver and biliary function, we're going to see dramatic changes with our patient. This is where big successes happen, and often very quick successes, is when we start to detoxify and improve the health of a patient that has an otherwise burdened liver. So if we review the anatomy, and we did a little bit of that last time with lower digestive, the liver has two blood supplies. It has a blood supply that's oxygenated from the hepatic artery, and it has the nutrient supply from the hepatic portal vein, which is the portal circulation, which we talked about in the lower digestive function last time, of all the foods that are being delivered to the liver for storage and processing. So the liver has a couple of main lobes, 4 total, but 2 main lobes, which are made up of thousands of lobules, and these lobules are made up of thousands of hepatocytes, and ultimately these hepatocytes are doing their job, which we'll talk about. There's multiple dozens and perhaps hundreds of jobs that the liver does, but we think of it primarily as our detoxifying organ. And so the common thing that we think about is the production of bile, and that bile gets gathered up into those lobules and into larger and larger ducts until it finally forms with the hepatic duct, and that's where we store, from the hepatic duct we go into the gallbladder, and that's where we're storing this bile. So the thing that makes the liver wonderful and unique is that it has the ability to withstand quite a bit of damage before we notice any sort of failure in body functions. So it's suggested that the liver can lose up to 3/4 of its cells before it starts to fail with keeping up for the demands of the body. So, like I said, more than 500 vital functions have been identified in the liver, and many of them you're pretty aware of. Things like production of bile to help carry away waste, obviously to help break down fats in the small intestine, the production of proteins, the production of cholesterol, obviously the production of the lipoproteins which carry cholesterol and triglycerides throughout the bloodstream. It does the job of converting excess glucose into glycogen for storage. It also helps us bring our fats and break them down and turn them into energy and glycogen and glucose so that we can turn our fat into fuel later. It processes and recycles hemoglobin so that we're not needing to consume as much iron because we're recycling it. It helps with the conversion of ammonia to urea. And we could spend another hour talking about all the different things that the liver does. So let's just go into talking about some of the functions of the liver and why it's our highest, priority of groups with the digestive system. So high priority number 2, liver and gallbladder, which is group 5 on the symptom survey. So if we look at group 5 on the symptom survey, you'll see 3 columns. And if you wanted to keep it very simple, you could look at the first column and say, well, those are symptoms that are mostly related to the liver proper. And you could take that middle column and say those are symptoms that relate to the gallbladder, or the biliary system more than the liver. And then the third column, 91 through 97, tends to be questions a little bit more about hypersensitivity reactions, which I tend to think of as being allergy, sensitivity, or histamine response problems. So if we pay attention to our physical examination, we think about looking at Murphy's sign, which is tenderness over the costal arch on the right hand side of the gallbladder, tenderness over the ileocecal valve or McBurney's point, and obviously sensitivity in the right thumb web. So some of you may not be chiropractors. In my chiropractic experience, right thumb web is a really powerful indicator to how the gallbladder is doing, along with palpatory tenderness on the arch of the right foot. Also important to remember is the large intestine, palpating the large intestine, palpating the iliotibial band. That also gives us some insight into how the liver is managing phase 3 detoxification, which we'll cover in a minute. So Confucius says, "He who learns but does not think is lost, and he who thinks but does not learn is in great danger." So today what we're trying to achieve is learning about how the liver talks to us, how it tells us that it's diseased, how it tells us that it's stressed or burdened or toxic and needs help. So we're learning to think. So when I'm thinking about the clinical correlations of the liver, of course, if I've given my patient the symptom survey, I'm looking for 2s and 3s being marked in that group 5. And I'm thinking of other things, or I'm listening to the patient as they're telling me their chief complaints. So I'm looking for pains that are roaming or moving around. So pain is in the shoulder this week, and next week it's in the hip, and next week it's in the foot. So it's a person that has aches and pains that roam or move. I think of the patient who's unusually grouchy, unusually angry. But by the same token, I also look for patients that I sort of expect should be angry, and they are like totally not angry. So I can see too much or an absence of anger as being an imbalance in liver qi. I see top of the head headaches. I see problems with bad breath. Of course, that's question number 93 on the symptom survey. When I see patients that wake up between 2 and 4 a.m. in the morning, I'm thinking this is probably a blood sugar issue, which could have to do with how they're managing fats, which is a biliary problem we'll talk about. But it can be when the liver is kind of regenerating. That's that horary cycle where the liver is regenerating between that 2 and 4 a.m. in the morning. Of course, I'm looking at patients that are consuming a low-fat diet. So I'm asking those kinds of questions. What is it that you're eating? I'm looking for symptoms of constipation. I've got top of the head headache on here twice, so that's doubly important. A history of hepatitis or gallbladder removal. Any history of cancer is always a toxic liver. Any history of hives or heat rashes that occur frequently, I'm thinking, okay, we need to look at liver. Some of the objective things that I'm looking for, we talked a bit about the McBurney's point, arch of the foot. Other things I'm doing is I'm palpating the liver. I'm palpating that right upper quadrant and seeing if they're flinching, seeing if there's any tenderness or sensitivity. I'm looking at labs when they're available, so I'm looking at things like the AST and ALT. I'm looking at LDH and GGT. I also look at albumin. If I see a decrease in serum albumin, I know that liver may be having difficulty packaging amino acids. And an elevated diastolic blood pressure. So for those that don't remember, the diastolic blood pressure, that lower number on the blood pressure, is the blood pressure when the body's at rest. So when it's the resting pressure. If I increase or congest the liver, blood flow through the liver is going to be slowed, and we're going to get a backup of blood in the periphery. So the pressure is going to be higher. So the resting pressure will often be slightly elevated. So when you see that 120/100 patient, I'm thinking, well, they're cardiovascularly fit, but they've got some back pressure in the liver. Of course, when we see that, we typically see things like hemorrhoids or varicose veins, water retention in the lower extremities. Another thing that I look for is the complexion of the patient. If they look a little greasy, if they look a little sallow, which to me kind of means yellow and greasy, that to me means that they're probably laying down cholesterol in their tissues more aggressively, and that's a sign that the liver is under functioning. I'm looking at the tongue. I'm looking at the nails. Obviously, when you think of the typical toxic hangover type person, they're coming in, they have very bloodshot eyes. I'm also looking at the person that has diabetes or metabolic syndrome. So most clinicians would agree that liver involvement is an almost universal entity in the treatment of chronic disease, but that early diagnosis by laboratory methods is difficult because you can damage so much of your liver, a fifth of it, before you start losing functioning. A fifth of the remaining portion, not 1/5, but a fifth of the remaining. So you can lose arguably 80% of your liver and still have relatively normal labs if it's a chronic problem. And this is from the Therapeutic Food Manual. So this was written by, Royal Lee and colleagues 70 years ago. At that time, they were talking about 60 known and identified functions of the liver, most of which are poorly expressed from a symptomatic viewpoint. Yet that's exactly what we're trying to achieve today is how can we look at the symptom survey and determine whether this is a liver problem or something else. This is why we have to learn how to think. So first of all, how does the liver become stressed? What's the overarching problem that we're seeing? Arguably, number one is the overconsumption of carbohydrates, processed and unhealthy foods, particularly trans fats, rancid oils. The thing that most people consider is environmental toxins, which is usually at the front of my patient's mind when I say, have you had any liver problems before? Are you around any toxic elements? And they're like, no, I don't use, spray paints or varnishes or things like that. So they're typically thinking about external environmental toxins as opposed to the things that they're putting in their mouth. And lastly, lack of exercise is really shown to have quite a big contribution towards creating problems burdening the liver. So those stressors encourage bile production and delivery problems. They burden the detoxification pathways, which increases the toxicity and ultimately altering digestive function. So it's not uncommon to see patients with several symptoms marked with 2s and 3s in the liver group because the liver will affect so many other areas. So like I talked about, most people are concerned about their environment, the things that are outside of their body. And there's no doubt that all of us are in a ubiquitous soup of chemicals. We're in contact with pesticides and industrial compounds and solvents and plastics and parabens and petrochemicals. And even things like DDT, which have been banned for decades, are still found in our blood. So these things are, I hate to say they're not things we can change, because I think we should all endeavor to work for a cleaner environment. But I think we all start with the same sort of baseline level of external environmental toxins. But where we have our biggest impact on things that we can change, particularly more immediately, is things that are going into our mouth. So our internal environment is far more important. So foods are the largest contributor to either burdening or unburdening our body. So the average American is eating a diet that's very low nutrient density, very high glucose, and very toxic. So these high carbohydrates, trans fats, processed foods are increasing the likelihood of yeast overgrowth, parasite invasions, malabsorption is really common, toxic bowel, constipation. All of this cumulatively impairs the ability of the liver to remove those toxic wastes from the body, all of which increase the risk of disease and dysfunction. So when the liver is burdened, the entire system is toxic, the entire person is burdened. So I'd like to talk about Spanish black radish really quickly, because it's topical and it's timely, and it's amazing some research that's been done by Standard Process recently, because in the past when we talked about liver detoxification, we talk about the phase 1, phase 2, and recently people have started talking about phase 3 detoxification. And many of you are probably pretty familiar with these. And in the past, we kind of focused on sulforaphane as one of the major contributors to, phase 2 detoxification pathways and improving liver detox. So for those of you that haven't seen it, I think what I'd like to do is I want to play a YouTube video that kind of discusses the recent research that's been done by Standard Process and the role of Spanish black radish.
Epidemiological studies have associated consumption of cruciferous vegetables like radishes with better health. One theory on why this is has to do with chemicals in crucifers called glucosinolates. These glucosinolates have been associated with increasing liver enzymes shown to improve detoxification of chemicals. After testing Spanish black radish extracts in liver cells, the Standard Process lab designed a mouse study to dig deeper into how these chemicals affect liver detoxification enzymes. After 2 weeks of mice being fed a diet of Spanish black radish, we have associated consumption of cruciferous vegetables like radishes with better health. One theory on why this is has to do with chemicals in crucifers called glucosinolates. These glucosinolates have been associated with increasing liver enzymes shown to improve detoxification of chemicals. After testing Spanish black radish extracts in liver cells, the Standard Process lab designed a mouse study to dig deeper into how these chemicals affect liver detoxification enzymes. After 2 weeks of mice being fed a diet of Spanish black radish, we exposed them to a toxin commonly found in char-grilled foods and cigarette smoke called dimethylbenzanthracene, or DMBA. In these mice, we examined the expression of 9 liver detoxification enzymes, how quickly the toxin was cleared from the blood, and the effect of the toxin on bone marrow stem cell numbers. Liver tissue from the mice was evaluated by real-time PCR and showed that overall phase 1 and 2 enzyme expression was increased in the mice consuming the Spanish black radish diet. But gene expression may not translate into actual enzyme activity, so we also examined how quickly the toxin was cleared from the blood of mice. Using HPLC, we were able to conclude that at the 6-hour, toxin concentrations were 47% lower in the blood of mice consuming the Spanish black radish in comparison to the control diet. After looking at the expression of liver detoxification enzymes and the actual time it took to clear out the toxin,
So I thought it was easier for me to play that video than to try and describe that, because it's such a great little concise collection of exactly what they did. So it's important to remember that beyond providing the best whole food supplements on the planet, they're continuing to look into why they're the best, and I think it's great that Standard Process is doing that kind of research to further bolster our understanding of why whole food is the way to go. So, many of you probably saw this little handout in your boxes and things, and you may have perused it and not really looked at what it was that they were testing. But that was a pretty profound test when they're looking at all the different factors of how, they proved gene expression, but did gene expression actually encourage the production of those enzymes that were protective? So they went that next step and that next step. So what a great test, and I look forward to more and more of those from our research, because I know they're going to be fantastic, because my results with my patients are fantastic. And I don't even use Spanish black radish that much. Now, I do use Liviplex, we'll talk about that later, which contains Spanish black radish. But, I mean, talk about a product that I don't use that is profound, at least from, straight up, I don't use Spanish black radish very commonly. Normally, I'm going to use something like Liviplex instead. So when we're looking at those, what else increases those phase 1, phase 2 enzyme, I'm looking at products like Cruciferous Complete, which is basically a Brussels sprouts and kale. I'm looking at SP Green Food, which is Brussels sprouts and kale, along with some barley grass juice and buckwheat juice, and that's obviously part of the purification program, along with SP Complete and SP Cleanse. And later we'll talk a little bit about Liviplex and Livco and Livton, which sort of brings us to the idea of the purification program, which I'm not going to talk about today. I think we want to spend an entire hour just on the purification program and a little bit more behind that phase 1, phase 2, and phase 3 detoxification. But today I want to focus a little bit more on just the symptom survey and liver and how it works. So it's entirely excellent when you're seeing lots of 2s and 3s in the symptom survey in the liver category, category 5, to consider doing a purification program. However, I would warn you or caution you that sometimes jumping into a full-blown purification program on a liver that's extraordinarily toxic could be too much too quick for some patients. So I will often do kind of a mini cleanse or a little bit of something like AF beta food or Liviplex as a preliminary in preparation for getting that patient a little bit more aggressive with something like a purification program. And like I said, we'll talk about that purification program in its own hour later in the process of building a comprehensive nutrition practice. So one of the things that we talked about, what causes liver failure, is exercise. And obviously when we're talking about exercise, the thing that comes to my mind is, well, if we exercise, we increase blood flow. And if we increase blood flow through the liver, obviously we're going to have more opportunity to filter and or detox. And that makes sense. But the thing that we're also finding is, particularly in people that have a more advanced stage of degeneration in the liver, often what we call fatty liver degeneration, becomes even more effective when we add exercise to the equation. And I think we're going to learn a little bit more about why that is when we start talking about blood sugar dysregulation, which will be next time's topic. So you'll see here on the conclusion of this study of type 2 diabetics and liver fat, you'll see besides the expected exercise-induced improvements in fitness in general and central obesity, a novel finding from this randomized study was the reduction in hepatic fat. I'm not sure this is novel. I think this is physiology. Novel sort of tells us a surprising or unexpected finding. I know that when we exercise, we make the body more sensitive to insulin. If the body's more sensitive, we need less of it. Insulin is what drives the deposition of fat into our tissues. So if we increase exercise, we decrease insulin. We decrease insulin, we decrease fat accumulation. And we're going to do it not only in the abdomen, but we're also going to do it in the liver. So this is not terribly surprising, but know that this is probably the mechanism by which we're getting the benefits from exercise, is by how we're influencing insulin. So another study on metabolic syndrome and non-alcoholic fatty liver disease. So to summarize, basically uh, exercise and managing blood sugar is going to help with improving how the liver responds and how it takes on its fatty deposition. So that's kind of the most common causes or things that are causing, the chronic liver degenerative processes. The other things to consider when the patient is presenting with you is, does this person have hepatitis? So this is probably the most common cause of chronic liver failure. Are they a long-term alcohol consumer? Have they had a diagnosis of cirrhosis, which is generally coming from alcohol consumption? Are male patients typically Northern European will have possibility of hemochromatosis, so they're going to get a lot of iron deposition in their liver. So anytime I see jaundice, anytime I see the yellowing of the eyes or their hands look a little yellowish, their skin, their flesh doesn't look pink, it looks more yellow, I'm thinking hepatitis, I'm thinking hemochromatosis, things that are causing liver damage. And of course what we just talked about, malnutrition. So people that are eating a high caloric diet but a low nutrient diet. Then there's a few causes of acute liver failure or very rapid liver failure, and these are different than the causes of chronic, and these are typically Tylenol overdose. So the number one by far cause of liver failure is taking too much Tylenol. Viruses, hepatitis virus can cause more acute and severe liver damage, particularly in children, and reactions to certain prescriptions, and tainted herbal medications. I included that because I kind of wanted to spend a second talking about why MediHerb, our kind of sister um, company that provides herbs out of Australia, why they're so good and so trustworthy. So in the United States, of course, there is a benefit of the FDA not having terrible oversight over our herbal products, because it allows herbalists to grow their own and do their own thing without a lot of heavy government oversight. But at the same time, that does offer the nefarious herbal producer or the ignorant herbal producer to be putting things into their product that may be deleterious or may not be the correct herb. That's where using MediHerb in your practice gives you a certain peace of mind, because you know that they're going to the trouble of sourcing the correct herb, they're processing it, they're using things like HPLC and different types of chromatography and things of that nature to make sure that what's labeled on the bottle is what you're getting. And obviously, you can consider that that the patient may be out harvesting what they think are morels and are in fact not morels. So poisonous mushrooms are a cause of acute liver failure. Not one I've ever seen, but obviously something to consider. So for a second, it's very important that as a chiropractor, I like to talk to my patients about the deleterious effects of drugs and why drugs are not always the best answer. And when we look at this study, and of course, it tries to take the blame off of things like, NSAIDs are very frequently prescribed, and hepatotoxicity from taking them is very rare. But because so many people are taking them, we're bound to have some liver damage. So we know that women, people aged more than 50, and people with arthritis are going to be at a higher risk factor for drug-induced liver injury. Why? Because they're taking far too much acetaminophen and or ibuprofen or naproxen sodium. So if I can influence a patient's pain, if I can manage it and get them off of these things, I'm doing some pretty profound things with regards to improving liver function. So recently I had a patient who, this is off topic, we're going to take a little detour, who has terribly heavy menstrual bleeding and menstrual cramping. And so I put her on Chastry to manage her hormonal profile, and I put her on Cramplex. And she came back to me the following month, and I said, "How was your period?" And she said it was remarkably lighter, but that's not important. The importance is I hardly had any cramping at all. I have been taking 18 to 20 ibuprofen a day while I'm having cramps to manage the pain of my cramping. And the Cramplex has made it so that I didn't have to take any ibuprofen or Tylenol to manage that pain. So even though that's off topic, I think it's important to hear how effective a product like Cramplex can be for something that's very simple, but obviously something that's causing acute liver failure in a lot of women out there. So that's a little clinical protocol. So we're getting to the slide that I wanted to talk about the most, and this is really what I wanted to base the entire talk about. If you don't have bile, you don't have liver regeneration. So this is a study from Science and with some from the Journal of Hepatology. And I'm just going to read it outright because for those that may be joining us on the phone, I want them to hear this idea. And the first part of it isn't unusual. Most of us know this, that bile acids are produced from cholesterol in your liver and then flow into your gallbladder where they are stored and concentrated as much as fivefold. And as your body senses the movement of fat into the small intestine, the gallbladder releases the bile to emulsify that fat, making it easier to absorb. As the bile continues through the digestive tract, 90 to 95% of it is reabsorbed from the large intestine and returned to the liver, where it is reused as many as 20 times. With a healthy gallbladder, proper amounts of bile are released into the digestive tract as needed. So I think it's fair to say that most of us know this. This is kind of part of our education. That reusing, that 90-95% is getting reabsorbed. Yeah, I think most of us might have had an idea, but maybe not how profound that is. So it goes on to say, without a gallbladder, there is a continuous trickle of bile into the system regardless of the presence or absence of fat. The failure to match bile output to fat presence jeopardizes one's ability to properly digest fat, we knew that, and eventually leads to deficiency in fat-soluble vitamins, we knew that, and essential fatty acids, poor cholesterol metabolism, and the absorption of improperly digested fat globules. We knew that. But what this found that kind of struck me as interesting is this last sentence that says, recent research has shown that exposure to higher relative amounts of bile acids triggers regeneration in damaged portions of the liver. So that 95 or 90% of bile that's reabsorbing is actually going back to heal the liver. It continues, which helps explains why individuals who take drugs that sequester bile acids, such as certain cholesterol-lowering drugs, cannot regenerate their liver tissue. So when we see a person who's taking a bile acid sequestrant, obviously that drug is binding bile, which allows them to excrete and eliminate more cholesterol, so it lowers their cholesterol. But when you reduce the ability of the liver to have that reflux or that return of bile, it actually damages your hepatocytes. So with that in mind, we're going to start talking about the symptom survey. So we spent a moment talking about, how the first side is liver, middle is biliary, and the right side is sensitivity. We've already talked a little bit about the idea of the examination component. So what I would like to do now is look at some of the questions independent and how they relate to each other. So we're going to start with questions that are typically more about liver and toxic bowel function. So this is questions 80, 81, 88, 89, 96. These tend to relate to a toxic bowel, which is what we can think of as kind of that phase 3 component of detoxification, which is the elimination of waste from the colon. So as the liver dumps its processed material into the bowel for removal through the feces, if there's any constipation, loose or watery stools, waste material is not being removed appropriately and just sitting around dumping back in our faces. So question number 80, we're going to go through each of those. Question number 80 is about bitter metallic taste in the mouth in the morning. So a metallic taste in the morning, or a metallic taste in your mouth, its medical name is dysgeusia. whether or not that matters. But that can be from several causes. The first cause that comes to mind is this a drug reaction? So certain drugs will create a metallic taste in your mouth. For instance, Biaxin is one, which I don't even know what does. Penicillamine, which is sometimes used for treating rheumatoid arthritis, can cause a metallic taste in the mouth. The ACE inhibitors can do that. So I'm always looking at a patient's medications that they're on just to double check that that may not be the cause. But this is a great opportunity to take another detour, to step off the liver presentation for just a second, because when you have dysgeusia, when you have that metallic taste in your mouth, frequently your taste buds aren't working correctly. And in order to have appropriate gustation, or the ability to taste, you have to have zinc in the taste buds. The zinc is working enzymatically in the taste buds to create that sensation of taste. So some of you may or may not be familiar with the zinc taste test. And the idea of that zinc taste test is, if I have a patient that I expect may be deficient in zinc, I put a couple droppers full of that liquid into their mouth, and I ask them to tell me, what do you taste? What does it taste like? So a person that has sufficient zinc will tell you that it tastes like metal. It tastes like you put pennies in my mouth. Pennies are made of zinc. But if a patient has already a constant bitter metallic taste in their mouth, and often you'll give them the zinc taste test and they'll say, I don't taste anything. It tastes like water. Now, you may also have patients that don't have that metallic taste in their mouth, and you give them the zinc taste test and they tell you it tastes like water. Again, that's telling me that those taste buds are underfunctioning, and that's likely a zinc deficiency. So the other thing, as soon as I see that bitter metallic taste, I'm asking about drugs. I want to look at their fingernails as part of my examination. If I see those little white spots on their nails, and I've got several of those, and I do the zinc taste test, and to them it tastes like water. Now I'm thinking less about liver, because they don't have any of the medications that may cause it, and I'm thinking more about a zinc deficiency. And of course, you remember that last time we talked about zinc deficiency leading to hydrochloric acid problems, because you need zinc to create hydrochloric acid. Without hydrochloric acid, you're not digesting your food. So we're coming back from the detour. Now we're back on liver. So bitter metallic taste, sometimes liver, sometimes zinc or drug reaction. 81 and 88 questions are basically the same question. In fact, if you look at the entire symptom survey and you go to the hypothyroid section, you'll see question number 129 is also about basically constipation. So 81, bowel movements are painful or difficult, and sometimes they will not check that, and they will check box number 88 because they are taking a laxative, and now bowel movements are no longer painful or difficult. So make sure that you know that these questions are duplicitous, or they're duplicated throughout the form, and understand why they may be answering things the way they are. And it's entirely possible that they're taking a laxative because when their bowel gets blocked up or they can become constipated, it causes problems with things like hemorrhoids and or fissures, things of that nature. So that's when you have to go away from that concept of liver and go into, okay, do we need to support collagen formation? So do we need to look at a whole food vitamin C, something like Cyruta Plus? Do we need to get them assimilating their bile more effectively and reabsorbing it? When bile doesn't reabsorb as efficiently, I think that's a surface tension problem, and that's where choline comes into play. That's why choline is on here. Choline helps improve the surface area, or helps bile work better. And so we get a better reassimilation. And when that bile reassimilates, it's very healing to our liver. And then we get the patient that stool alternates from soft to watery. And number 96 comes back over and over again, burning or itching anus, which henceforth I'm just going to call itchy butt. And this is generally because there's an aberrance in the pH of the bowel. It's either too alkaline or too acid. Now, in general, I want to keep the pH of the bowel slightly acid. This is going to improve the ecology for the good bacteria, which we talked about last time, and lower digestive function. So anytime I'm looking at problems in these questions, I'm really thinking about phase 3 detoxification. And when we look at the host of all the supplements that I think of when I'm thinking about liver and gallbladder, when I see those, what is it, 4 or 5 questions populated, I'm thinking about these guys over here as things that are going to influence lower intestinal function. So does that patient need fiber? Do we need to influence the pH of the bowel? Do we need to give some probiotic? Or do we need to just, they may not be producing enough bile. They may not have a gallbladder, so I may need to do something that's a kind of a gentle laxative with a little bit of cholesterol. For those of you that are unfamiliar, we're going to talk about that in a minute. And of course, if they're just plain old, constipated, magnesium lactate is a great gentle laxative, along with other things like disodium phosphate. But magnesium is a great laxative to get people that just have mild constipation moving. So I usually start with that, giving the patient, somewhere between 3 and 6 a day, and having them slowly increase it until they start to see an improvement in their bowel. So the next questions that were on the symptom survey that we're going to talk about tend to be more of interconnected questions or that web that we sort of talked about last time, and how these are connected to other symptoms. So number 73 is dizziness. Dizziness is on the symptom survey 3 places. It's here in liver, it's on hyperadrenal, and it's also number 157 in hypoadrenal. So this is kind of one of those vague symptoms that can be lots of other things. So anytime I see number 73 answered, I'm not thinking liver. I'm thinking, what else is really going on here? Is it liver? Do I have a lot of other signs that are leading me to think liver? Or is this more of a blood pressure dysregulation or adrenal problem? So this is a situation where Ragland's test might come in handy. I would be interested to know if anybody is completely unfamiliar with Ragland's. Why don't you throw it in the chat menu, and if that's the case, then we'll do a little video on how to perform Ragland's test and throw it up on the web page. But I am assuming that most people are fairly familiar with blood pressure laying down versus blood pressure standing up. If we look at questions number 78 and 95, these tend to be kind of thyroid-related questions. And in fact, similar questions are in the thyroid section, like hair that's coarse and falls out is also in the thyroid section. Intolerance to heat might be somebody that's manifesting more of a hyperthyroid situation. So when I see these questions answered, of course I'm thinking liver, but I'm also thinking, is it because they're not absorbing their fatty acids? If you don't have adequate fatty acids and proteins, you're not going to make a good hair follicle. But probably more importantly, I'm wondering, are they converting T4 to T3? So T4 is our primary, thyroid hormone, and we have to convert that in our peripheral tissues to T3, which is our more active form of thyroid, which really, is the one that gets the job done. That conversion takes place in the liver, 80% of it. So if the liver is burdened, we're going to see less conversion of T4 to T3, and that may be the cause why the hair is coarse, thick, falling out. If somebody's sensitive to heat, of course I'm thinking hyperthyroid, and when I'm thinking hyperthyroid, I'm thinking maybe the liver is not doing a very good job of filtering that excess T3 and getting rid of it. So that can be a problem as a liver issue there. I'm also somewhat considering calcium, a little bit of vitamin F, as vitamin F can also influence how the body's manifesting with regards to dry skin and calcium and iodine assimilation. Blurred vision is another. It's pretty direct liver correlation when you think from a Chinese medicine standpoint. Of course, that idea of the person that's intoxicated and their eyes are blurry and they can hardly see, we think of that being a kind of a temporary overburdening of the liver. So blurred vision obviously could be a visual problem, so I'm checking into that. But from a kind of a episodic recurring blurring vision problem, I'm definitely thinking liver. And it may even be a situation where liver is having difficulty just getting rid of histamine. And the last couple on that section are worrier, feels insecure, and bad breath. So bad breath, along with that metallic taste, could be the need for better digestive support. The stomach is not doing its job, so I want to correlate that to the questions in section 5. I guess 5 is digestive, or 6 is digestive. We're in section 5. I'm going to be very sure to make sure I check the patient's hydrochloric acid point to make sure that that's not part of the problem. If I've got a situation with really chronically bad breath, I'll often look into a product like chlorophyll pearls. Not only is that really healing for the gut, tends to manifest benefits with phase 3 detoxification, but it's very soothing and healing and very detoxifying for the tissues that it gets in contact with. So I'll even have patients chew those sometimes to see if that can influence a bad breath problem. And now we're kind of moving into a few of those hypersensitivity questions, the sneezing attacks and the dreams or nightmares. So when I'm seeing these, I'm seeing a situation where histamine levels are not being managed, and we need to remove histamine more readily. Or we're seeing a situation where perhaps either internal or external allergens are becoming more profound. So right now in Montana we're having some fires, and so I'm seeing a little bit more of a detoxification pathway issue as people are trying to get rid of this extra histamine and other additives of pollen and smoke that are in the air. And of course, number 94 is milk products cause distress, which could be a very simple digestive problem or a lactose intolerance. But when I start to see it in combination with lots of other things, I'm thinking, okay, this is a person that's simply just not backing things or clearing things out of the liver. So if we look at the old school literature, so this is the product bulletin, it talks about histamine working to oppose the effects of adrenaline, and that it acts as a gastric hormone stimulating the flow of hydrochloric acid. So an excess of histamine in an otherwise normal individual is likely to produce gastrointestinal, read heartburn, and cold-like symptoms. So anytime I have a patient that's presenting with heartburn, particularly GERD, that's waking them up, or they have a chronic cough and a chronic sore throat, which is really consistent with the person that's getting regurgitation of stomach acid up their esophagus and going up into their throat at night. And so, the first thing I'm thinking is, what time are they eating dinner, and what's their digestive potency look like? Is this a situation where I want to give Zypan and improve that? But occasionally you'll see it on a patient, and it just happens no matter what you do, and even if they're eating dinner at 6 o'clock. And, there's just no way that you can logically, because the transit time of the stomach is 2 hours. And so if somebody eats dinner at 9 o'clock and they go to bed at 10, I can see stomach contents not, still being in the stomach and regurging as a result of inefficiency of the hydrochloric acid system. But I'd like you to think about this. For the person that's eating early and not snacking, but they're getting heartburn at 2 in the morning, most likely that food has already left their stomach. So what's backing up is hydrochloric acid that's being made as a result of a histamine reaction in the small intestine. So this is the person that's probably eating something like gluten, or it may be dairy, could be other things, but those are the two most commons that are upregulating that histamine production. And when the liver gets burdened with that over time, because people don't just eat bad foods for a week and stop. They've been eating them all their life, and now they're coming to you. So this is when I'm talking about, let's try removing gluten from your diet for a while. So let's remove grain. Or if they put on there that milk products cause distress, let's remove milk from your diet and all milk-containing foods, and see how that affects your heartburn. Because my suspicion is that they're not bringing food contents up; they're releasing too much histamine. So if I can take away the burden that's causing that histamine production, I can improve that patient. So excess histamine can result from the putrefaction of proteins by certain microorganisms in the colon. And so this is exactly what I'm talking about. That food is in their small intestine making histamine. Histamine's causing their stomach to make more hydrochloric acid even when food's not present and causing the problem. So instead of giving, in the short term, we may have to give that person Gastrex to help soothe their stomach and their esophagus, things of that nature. But let's look upstream and find out what's causing that histamine. If the patient won't stop eating what's causing it, then we have to be really aggressive with getting the liver to detoxifying and getting rid of that histamine more readily, more aggressively. And nobody does that better than Antranex. So Antranex is a liver detoxification hormone. I've talked about it before. I'm not going to spend that much time on it. But basically what it's doing, we talked about it last time in portal circulation. Antranex is increasing blood flow through the liver, so we're having more opportunity, more chance to decrease the histamine content in the body because it's being eliminated by the liver. So I'm thinking about Antranex anytime I see hypertension. We talked a little bit about hyperthyroid manifesting as a liver problem. So again, if I can increase the filtration of the liver by improving hepatic circulation, then I'm going to get rid of more thyroid hormone and help the person with hyperthyroid symptoms. Persons with allergies, obvious is time to think of Antranex. Hyperirritability, toxemia. The person that had, when we talked about that top of the head headache, that's a cerebrospinal fluid pressure issue. We can balance that pressure by getting more flow through the liver. Antranex does that very well. The next questions are really 74, 75, 77, 79 are telling me, I need to absorb fatty acids more effectively, more efficiently. So number 74 is dry skin. Number 75 is burning feet. 77 is itching skin and feet. And number 79 is frequent rashes. So obviously bile is important for us assimilating the fats in our diet. But more importantly, are my patients even eating fat? This is probably the biggest problem with these questions is I need to ask them, what are you eating? Do you eat cold water fish? Do you know what a fish is? Are you doing any sort of flax oil, that kind of stuff? And when I find that this is the typical McDonald's patient, then this is pretty easy. I just need to introduce something like a tuna omega or something like that to start imparting better fatty acid assimilation just because they're simply not eating it. Then secondarily, as I start to look at the next section, gives me a little bit better idea, is this truly a bile problem? So I have plenty of patients that come in and they do eat a pretty decent diet. They tend to when they can, eat cleaner meats, grass-fed beefs and things like that, organically if they can, and yet we're still seeing these problems. So in those situations, they may be answering these questions, but it may be less because they need to eat fat and more that they need to assimilate it, in which case I would expect them to answer the next set of questions positively, which we're going to get to in just a moment. So support for these patients that are answering those last four questions, I'm looking at the things that are supplying good omega-3 fatty acids. Now, occasionally we'll run into a patient that isn't doing very well with omega-6 fatty acids, and that's what Super EFF comes along. This is a product that I didn't have a great understanding of until just recently, because some of my early education in nutrition really pounded this idea that arachidonic acid was bad. The omega-6 fatty acids are bad and the omega-3 fatty acids are good. Well, that's foolish. That's foolhardy. So, the idea being that, omega-6 fatty acids convert to arachidonic acid, and arachidonic acid leads to prostaglandin production, PGE1 and PGE3, which drive inflammation, and therefore are bad because we don't want inflammation. But I do think we need to step back and we need to remember that my car has both an accelerator and a brake. And to blame the accelerator as the problem for all car accidents, because if you weren't going anywhere, you wouldn't run into anything, is pretty stupid. So I want to have a healing process when it's important, and I don't want to have a healing, and I want to be able to finish that healing process with a brake. So when I'm thinking of omega-6s and a person that may be having difficulty completing bleeding and inflammatory process as a result of liver problems, I'm thinking super EFF. When I'm thinking the chronic degenerative processes that are having difficulty healing, I need accelerator, so I may need to give them super EFF, particularly if I see lots of liver burden. Now, we tend to think more along the lines of we want to do things that are going to help break or stop the inflammatory process. That's the omega-3s that we're going to be delivering with things like tuna omega, cod liver, blackcurrant, calamari. Of course, not listed on here is linum B6, which is flax oil, which really should be in this column as well. So when the patient is eating those things, but still answering those last questions, now I'm looking at these 80, 83, 84, etc. These all pertain to some form of primary gallbladder dysfunction. So when I'm seeing that gallbladder dysfunction or I'm hearing it from the patient, I'm going after my examination. I'm looking for sensitivity in that right upper quadrant. I'm looking at their right foot. I'm looking at their right thumb web. I want to correlate my exam to my findings, and I want to teach it to my patient, because with understanding comes compliance. So this is they're answering questions like they feel queasy, they're getting headaches over their eyes, their stools are light colored, and they're probably floating. This is the person that may have to flush 2 or 3 times to get that poop down the toilet. And I talk about patients about that because it makes sense to them. Poop that floats has more fat in it. Fat is buoyant. Obviously, if you shake up vinegar and water, or vinegar and oil, the oil rises to the top. So poop that has more oil in it tends to be lighter colored, tends to float. Of course, the person that's not absorbing fats very well is getting the majority of their energy from carbohydrates. And carbohydrates to me are kindling. They start a fire, but they don't maintain it. So if I'm eating a carbohydrate that's kindling, pretty soon that's going to be burned off very quickly. So I'm going to be going right back to eating more sweets. So I'm constantly eating sweets to keep my metabolic fire burning, because I'm not assimilating fats, and that's driven by biliary function. So when I see this, of course, we're going to talk more about this next time with sugar handling. I really want to work on getting a patient eating a better, more balanced, managed carbohydrate or appropriate carbohydrate diet, something like the Melvin Page Phase 2 diet. I'm not against the paleo diet. I'm not against Atkins. Any diet that moderates and gets people eating a more appropriate amount of carbohydrate is a good diet. Skin peeling on the soles of the feet is a very strong sign of biliary insufficiency and liver congestion. Same thing, obviously greasy food upsets, pain between the shoulder blades. Anytime, I'm a chiropractor, anytime somebody comes to me with pain between their shoulder blades, even though it may be a simple mechanical problem, I'm always asking the question, do you have any problems with bloaty, belchy, burpy, gassy? Even if they're not interested in nutrition, I'm looking at that, and that gives me an opportunity to make an in with that patient when I can fix a problem that has not been fixed previously simply by doing something like addressing the obvious. That's not a middle back problem. That's a referral pattern from the gallbladder. So obviously bile is made in the liver, stored in the gallbladder, and it's a component that many medical doctors feel that we can live without. And as a result, approximately 750,000 people in the U.S. are losing their gallbladders to surgery. This is criminal. So number 90 is gallstone, gallbladder inflammation. This is the person that's going to be a lot more hot, a lot more sensitive over that right upper quadrant. And often they may have some constipation. If that is the case, we need to make sure that we're getting the bowels moving. So if we need to do something more aggressive to improving constipation, like obviously a fiber or a magnesium or a disodium phosphate or even a Colax in the short term just to get them moving their bowels, that's going to help us clear out the biliary tract. So the thing that we want to pay attention to, not only apples, but primarily beets. So this leads us to a little bit from Royal Lee, and I'm just going to read it. One of our common results of this high cholesterol problem is gallstones. When you have gallstones in your gallbladder, they're precipitated forms of cholesterol. I might give you a little tip here. Many doctors have told me they've never had an operation for gallstones anymore once they discovered this little trick. The fact that the beet leaf juice will prevent cholesterol precipitation in the gallbladder. The juice of the green leaf of the red beet. We all know what beet greens are. The juice of the beet greens is the most potent thing that I know of to relieve the distress of the typical gallbladder patient. It's a simple remedy that anyone can try out with no possible harm, and it is, I am sure, from my experience, capable of relieving at least 90% of gallbladder patients. I would have to agree with Royal Lee. I use lots of beta food and AF beta food. So I've got a couple of references from the clinical reference guide and the product bulletin talking about the importance of the primary constituent of beets, which is a chemical called betaine. And if you listen to anybody from England or Australia, they tend to call it betaine. And what we do know is that betaine is really powerful in converting homocysteine, which is a dangerous metabolite of amino acid production, into methionine, which is benign, doesn't cause any problems in our bloodstream. So many of us in our kind of general education have learned a lot about folic acid as being the guy that helps convert homocysteine back to methionine, but nothing does it better than betaine. Of course, when we think of B9, folic acid, we think of leafy green vegetables. And what is beet leaf? A leafy green vegetable. So very important we're providing this betaine, because betaine not only thins the bile, not only is it a cholagogue, so a cholagogue is something that helps you make more bile. And a choleretic is something that helps you secrete more bile or thin the bile. And so AF beta food acts as both a cholagogue and a choleretic. So vitamin A and vitamin F are going to promote liver function. So by adding those two to beta food, we're getting a little bit better function or a little bit better functionality. Now, it depends on the patient. I will sometimes give straight beta food when I think that they need more betaine more rapidly. So when I've got a hot gallbladder, I may do one over the other. And if I have a strong suspicion that there may be a gluten sensitivity, I tend to do more of the straight beta food. So there are several studies on betaine. The other name for betaine is trimethylglycine. So for those of you that get pimped by other nutrition companies, they're often trying to tell you how amazing and how profound their trimethylglycine is. And I always just sort of smile and I nod and I say thank you for the information, and I go back to using beta food. Why? Because there is no better trimethylglycine product on the market than beta food. So we know that homocysteine can cause an increase in insulin resistance. If I can keep homocysteine in check by lots of trimethylglycine, in this case beta food or AF beta food, I can manage insulin resistance. This is why this is so powerful and why we're going to talk about it so much next month when we're talking about blood sugar regulation, because I can affect insulin with it. So one of my absolute home run, go-to all the time, have to have on my shelf, stocked up, AF beta food, because I use it so much, because it does so many things. So if we go back old school and we look at the therapeutic food manual and we're looking at things that manage biliary stasis, you'll see number 1, AF beta food. You'll see number 2, betaine hydrochloride. Betaine hydrochloride and or Zypan, things that with hydrochloric acid, stimulate the release of bile from the gallbladder, along with fat in the food that you're eating. So if you're consuming fat but you don't have hydrochloric acid, you're not going to stimulate the gallbladder to release bile. And if you're not making it very effectively, AF beta food is going to help produce that. If the bile is not detergent enough, it's not working well enough, that's when we do things like choline. We talked about that briefly earlier. For the person that's really having a whole lot of cholesterol backing up in their skin, that's when I add choline. Choline is for the person with that sallow complexion. But by doing those top 3, those first 3, that's a big 1, 2, 3 punch for improving biliary flow and biliary function. Finally on that list, you'll notice disodium phosphate. This is a product that I've kind of had, hot and cold relationships with. I used to use it a lot for constipation, and it always worked. It really worked really well. And I don't have any reason not to like it, but I just have gotten more in love with using more AF beta food or magnesium because I think that provides some muscular benefits above and beyond what disodium phosphate can do. But the reason it's there is because that gets the colon clearing out. I know disodium phosphate will get a patient pooping right away. So if I need to get the constipation cleared and the gallbladder working, disodium phosphate is the way to go because I guarantee that's going to get your patients pooping right away. So obviously AF beta food is an excellent source of beet leaf and beetroot. That's what it is. Beta food is just beet leaf and beetroot juice. AF beta food has a little bit of vitamin A, a little bit of vitamin F. Of course, I'm not going to, we're already a few minutes over. I think most of you can look at this and read these bullet points. So when I'm using AF beta food, I'm typically using 3 to 6 per meal, particularly when I've got any indications that there's a sensitivity on that right upper quadrant with palpation, or if I've got pain between the shoulder blades. And in some patients that are just mildly problematic and have a little mild constipation, I'll sometimes just use AF beta food or beta food by itself and have them titrate the dose up until they start to loosen the bowel. So so I may tell a person take 3 per meal today, 4 per meal the next day, 5 per meal the next, 6 per meal the next until you start to poop. Or if you start noticing your poop is turning red, which is the beet, then we can back it back down to a dose of 3. And with patients that are interested or will do it, I'll have them eat a beet. So I'll say go to the grocery store, buy some beets, chop them up, throw them in the oven for 40 minutes on 300 degrees or whatever, soften them up, put some butter on them, and eat that beet. That is an amazingly quick means of getting most people eliminating. And obviously remind them that if their poop turns red, that's not blood, that's the coloration of the beet coming out of the stool. Now occasionally we're going to run into a patient that has already had their gallbladder removed, or they're showing such signs of gallbladder, duct blockage that we have to send them for emergency services and have that gallbladder removed. So in that situation, that person is not going to be concentrating bile. They're not going to be storing it. They're just going to be constantly dripping it. And that's where a situation and if you have that problem, guess what? No bile means no liver regeneration. So they're going to slowly show chronic liver degenerative problems because they're not putting or recycling that bile through. Cholecol is our answer. It provides them the opportunity to have the bile available when they're eating, which is when they need it because they need it to emulsify their fats so they can absorb their fat-soluble vitamins. And so that they don't have so much fatty mass in the fecal material that it's coming out of them rapidly. So frequently with patients that have had gallbladder removals, they tend to avoid fatty foods because it gives them diarrhea or explosive stuff coming out of their butt. And this is what I'm talking to them about. I'm like, listen, we can influence that by giving you bile for those meals that are higher fatty content. So patients without gallbladders often experience diarrhea. Oftentimes they get constipated because they're eating not really good fat, foods that don't contain much fat because they know if they do eat it, they'll get diarrhea. So then they go between constipation and diarrhea. One thing that my patients that I make them understand is that bile, even though we think of it as being a vile and irritating, substance, it's actually quite calming, quite good for our intestine. I tell patients bile is like aloe vera for your guts. It makes them happy, makes them healthy, and now I'm telling you it heals their liver. So of course, if they're not digesting or absorbing their fats, they're not getting vitamin A, vitamin D, vitamin E, vitamin K. That's why they're getting all those dry skin problems that we talked about in those previous symptom survey questions. So cholecol is bile.
bile salt. So we're basically giving them bile. And a little bit of Collinsonia root. Collinsonia root is a venous astringent, so it tends to tighten up the veins of the hemorrhoidal plexus. So too much bile too often can cause problems with hemorrhoids. That's why Collinsonia root is in Cholacol. But more importantly, I want to take the time to teach that patient how to take their Cholacol, because I want to try and mimic how the body would do it. Because people, people obviously have plenty of bile when they're making their own and they have their own gallbladder, but the body is infinitely intelligent, so it knows how to secrete bile when you eat an apple versus how to secrete bile when you, for instance, I don't know, eat a bowl of lasagna. So I talk to my patients about taking it in relationship to how much fat is in the meal they're eating. So I'll say, in general, let's have you take 1 or 2 per meal. If you're going to sit down and you're going to eat something that doesn't have any fat in it, like a piece of fruit or a carrot or something like that, you don't need to take any. And if you're going to sit down for some sort of large, opulent turkey dinner or something like that, you may want to take 3 or even 4 to help you manage and absorb those oils that are in that meal. And the way that you're going to be able to tell is how your bowels are performing. So if your bowels are well formed, coming out easily, not without the need for a lot of wiping, you're probably doing it right. So a few other things to consider. Oh, I don't know I think we're off on the slide here. I'm going to go forward. Well, I think we're missing a slide. Anyway, I'll put that in there later. This kind of gets us to the end, or close to the end. We're talking about Liviplex. Liviplex is kind of the go-to product when you can't decide what to use. Do I use choline? Do I use Betafood? Do I use histamine or Antronex? What do I use? Liviplex has all of that in there. So choline is also a product that's in Liviplex. It's not listed in the clinical reference guide, but if you look at the bottle, you'll see that there is choline within Liviplex. So there's a few interesting studies on choline and its importance with regards to improving how the body functions. Helps with brain development. It helps with weight loss. It particularly helps with regards to helping women, particularly older women. So I've got a couple studies here, the effects of estrogen and genetic variation with women that are doing and not doing choline. So the conclusion of this study, for example, is because of their lower estrogen concentrations, postmenopausal women have higher dietary requirements for choline than do premenopausal women. So by getting them absorbing more fats, they're more capable of creating and maintaining the estrogen levels that they have, even though their ovaries have shut down shop. Here's another quick little study that you can look at later. And that kind of lends us to that last section, which was improving biliary function, and that's primarily the AF beta food, and things like Livco and Livton. So let's spend a minute and talk about those guys. Livco and Livton are the MediHerb products that I use when I'm looking at liver function. And the way that I think about it is I think of Livton as my liver tonic. And this is for the person that I'm trying to improve that biliary function. So if I need a cholagogue or a choleretic, something to make more bile or help with the secretion of bile, I'm thinking Livton. So in the I use Livton in patients with chronic gallbladder problems that I've had on AF beta food or beta food, or the person that I'm trying to save their gallbladder from having to be removed. So this is kind of my next step in the power hierarchy of improving biliary function. From a practice management standpoint, I will often perhaps start a patient on AF beta food, and then I will, after that bottle has run out, or when I expect that bottle should have run out, I will put them on Livton, and I'll tell them, okay, this is our next step in the cleaning out or purifying of the liver. So we're basically getting another avenue of how we're protecting, creating, and secreting more bile. Then I might put them, after that is done, I may go to straight beta food. So oftentimes it's that paying attention to the patient and kind of tweaking or changing their protocol that keeps them interested. Because change is, people like change, people like something new and different. So Livton is my more powerful, more expensive, but definitely different product that I can go about looking at influencing biliary function. As opposed to LivCo I tend to use for patients that have liver damage. When I see ALT, AST levels that are elevated, when I know they have hepatitis, when I know that they have fatty liver degeneration, and I need to give them as much liver function as possible, or I've got that alcoholic and I'm looking at their labs and ALT, AST are high, LivCo is my go-to product. LivCo repairs the liver. Now, milk thistle is in these. Milk thistle is arguably the most liver protective constituent on earth. So that's why both of these are very powerful products. It's the process of concentrating milk thistle, which MediHerb does any better than anybody on the planet. But what I think LivCo provides is the Schizandra. Schizandra is really profound at helping heal the liver. So for those difficult cases where a person is dying from liver failure, LivCo will buy you time so that you can get some liver regeneration. So remember, when we tug at any one thing in nature, we discover that it's attached to everything else. Don't forget to look upstream. Look for signs of signals that hydrochloric acid is adequate and producing. If you don't have that, you're not going to get the stimulation to the gallbladder and the liver to release the bile. Also make sure they're eating the right foods, they're getting out and doing some exercise, and make sure their daily habits don't include huffing glue. That's definitely bad for your liver. So I'd like to make everybody aware of some upcoming educational events, the SP West calendar of events. You can click on these, perhaps not now, but if you go back to the notes later, these are hyperlinks that will take you to the calendar of events. Of course, back to school is coming up September 14th and 15th. That's in Denver, Colorado. Everybody should do their very best to make it anytime Mark Anderson is speaking. Teleconferences in the future. We've got the Montana Nutrition Collaboration, which is the second Monday of every month. That'll be next Monday from 1 to 2. All the notes and information on that can be found on my webpage at Park County Chiropractic, which is probably where you joined today's webinar at. And of course, Mentoring the Mentors is Dr. Stuart White. That's every other month on the 4th Thursday of the month from 6 to 7. The next one of those is September 26th. And that is also a hyperlink to the notes that Stuart provides for his little conferences. Thank you, Donna. I appreciate the love, and for everybody that stayed on for an extra 16 minutes, I appreciated it, but I wanted to make sure that I got it all in one so that I didn't have to separate it into two teleconferences. And for those that didn't get it all, we definitely have it recorded, and I'll get that recording up on the webpage so people can access what they missed later. So thank you for joining us. If there's any quick questions, I'll address those on the chat menu, but I'm going to turn off the recording. And we'll see you all next month not next month. We'll see you in the month of October, where the very timely topic will be sugar handling and how we're going to see lots of that problem on November 1st. Thank you.